Yes, sir, you can start now.
So, a very good evening to all of you. I'm Dr. Abhijit Kumar from Zydus Healthcare Limited, and I would like to welcome you all in this the Cardiorenal Summit, in which the topic for discussion today is early diagnosis and management of hypertension and its renal complications. So, for this, we have our panel members and moderator. So, briefly, I would take you through the introduction of our speakers, moderator, and our panel members. So we have Dr. K.L. Arun sir, who will be our chief moderator. He is chief nephrologist, Department of Nephrology and Renal Transplantation at Malya Hospital, Bangalore. He has received Best Scientific Paper Award at Indian Society of Nephrology Southern Chapter Conference in 1997. He is a visiting fellowship at SUNY HSCV in New York, awarded by Karnataka State Medical and Dental Alumni Association, USA. He has more than 6 index publications and is a regular contributor to Karnataka Medical Journal. With him, we have our respected speaker, Dr. Girish MS Sir. He is assistant professor and consultant nephrologist at MS Ramaiah Hospital. He is a He is a leader in evaluation and management of acute on chronic and chronic renal failure patients. He is also an expert in insertion of acute peritoneal dialysis catheters and management of patients on acute PD and CAPD. Also, he is well versed in management of pediatric patients with renal failure and conservative peritoneal or hemodialysis and renal transplantation. Now, as panel members, we have Dr. Vivekanand S. Gajapati. He is the DM Cardiology and Consultant Cardiologist at SDM Narayana Hridayalaya, Dharwad. He has been Consultant Cardiologist at Usha Mullapudi Cardiac Center, Hyderabad, from May 2007 to February 2009. He is Associate Consultant, Department of Cardiology, Aditya Birla Memorial Hospital, Pune, in November 2006 to April 2007. He has worked as DM trainee in PGI MER in cardiology and has performed about 11,000 cath lab procedures, including more than 1,200 PTCA, more than 200 stenting, and also more than 50 EPS and RF ablation procedures. Our other panel member is Dr. Manjuna Toshiti. He is a nephrologist at Chirayu Hospital, Kalaburgi. He is founder, chairman, and medical director at Chirayu Hospital. He is talking about his achievements and awards. He is a gold medal in general medicine at the Gulbarga University in 1999. He has award-winning paper presentations at various state and national conferences like Capicon, Epicon, and ISHT 2006. He presented paper on non-diabetic renal disease in diabetes at World Congress of Nephrology in 2009 in Italy. He is recipient of Vikas Prerak Prashasti in 2010 by Bharat Vikas Sangam for selfless contribution in field of social medicine, and he is also a recipient of Vishnu Sen Award in 2013 in recognition of providing free treatment to poor patients. So with this, without wasting much of your time, I would now request our chief moderator, Dr. K.N. Arun sir, to please take over the session.
Thank you very much for the kind introduction. Thank you, Zydus, for giving us an opportunity to share a few thoughts about hypertension. We have indeed been through tumultuous 1.5 years to 2 years. Many of us have suffered losses to friends, family, colleagues, in addition to patients. And it has been quite challenging for most of us to have gone through this phase, and hopefully we may be looking at the end of the pandemic, and let's hope at least, even if there are further waves, they are not as bad as the previous ones were. Let us thank the Holy Trinity for having pulled us through this, and let me offer my prayers to Brahma, Vishnu, and Maheshwara for pulling us through this way. Talking of the Holy Trinity, Brahma, Vishnu, and Maheshwara, It is always Vishnu who is always thought about first. And when I ask you to name a few temples for Vishnu, I'm sure all of you will tell me about 100 names, starting from Tirupati up to Thiruvananthapuram. Similarly, Shiva, we all remember lots and lots of temples, right from Amarnath north up to Rameshwaram, deep south down. But when it comes to Brahma, how many of you can really name temples that have been dedicated to Brahma? Hardly any. Yeah, there is one in Pushkar near Pushkar, and another one probably some of you may know, which is close to Kumbakonam. But next to that, I'm sure all of you would find it difficult to name temples that are dedicated to Brahma. Why I brought this up is basically because this is how exactly the nephrologist feels when he's talking about hypertension. The cause for hypertension is the kidney, but rarely is the nephrologist thought about when hypertension is discussed. It is always thought to be the domain of the cardiologist or the physician, or by some people to the domain of endocrinologist, but rarely is the nephrologist thought about. If we remember that the kidney is the cause for hypertension, and it is the abnormalities in the kidney that cause even the so-called essential hypertension, where we have essentially failed to find out the cause for hypertension, it would be a great service to the patient if we involve the nephrologist early on and achieve better results in hypertension control. I'm indeed happy today that this role of nephrologist is being recognized, and in the last 5 or 6 years, most of the people have become aware of the role of nephrologist in hypertension, and I'm happy to have this distinguished panel with me who are going to teach us a lot about the various quirks in the management of hypertension. The close relationship between kidney and hypertension has been clear for quite some time, and the relationship between controlling hypertension and kidney outcomes has also become quite clear. For that matter, in before we started aggressively treating hypertension or the various contributors to renal disease, the loss of GFR for a patient with kidney disease would be as high as 10 to 12 ml per year. Now, in properly controlled patients, people whose comorbidities are well settled, who are compliant with their treatment and diet, we are able to achieve the loss of only about 2 ml of GFR per year. Imagine saving 8 ml of GFR per year, or in simple terms, providing a dialysis-free life for a patient for more than 10 years. That would be a great achievement, and that would be a great service you could be doing to the patient as well as his family. So recognition of hypertension early on, intervening early enough, and managing it properly makes a huge difference in the outcomes of target organ changes. I'm indeed happy to have Dr. Girish, who I know very well and is a great speaker. I always look forward to his lectures, and I'm very glad that he's here today to start off the proceedings with his lecture. My request, Dr. Girish, to give his lecture.
Thank you, sir. Thank you very much. So at the outset, I would like to thank the Zydus team for having provided me this opportunity, and to Arun sir also for having me as a speaker. So, and I'm very happy to have Dr. Manjuna sir and Dr. Vivekanand sir with me as our panelists. So my talk will be like more of a basic introduction, and then Arun sir will be taking us through some discussion regarding the further like management or the common doubts that will arise during our day-to-day practice. I will just share my PPT. A very good evening to everyone, and apart from the organizing team and us, the panelists, so it's all the people who are here who makes all the difference. And thanks for being here on this Saturday evening, and I heartily welcome you all for this. And this is the talk is mostly about like early diagnosis and management of hypertension, CKD. So this kind of scenario, there is no clear-cut demarcation where the hypertension stops and where the CKD arises, as Dr. Gandron has already told about this. So let us just briefly go through this. So usually, like we always start with the burden of any disease. And it's very well known that hypertension has become the most wide risk factor worldwide. And it is whether it's in the developed or in the developing countries, hypertension has taken the first rank now. So we are there with someone who has held the first rank. So which might be a bad thing, but nevertheless, it shows the importance that what we have to deal with in the days to come. And even in India, so the burden is so huge that almost like 1 in 4, at least 1 in 4, will be an hypertensive if at all properly diagnosed. So then if at all we come to the definition of hypertension, this everybody would have heard it time and again, like, okay, whether it's 140 by 90 or 130 by 80 or less than 130 by 80. So there are varying definitions. But what I want everybody to understand is that, okay, there is one cutoff. You take it either 140 or 130. So, but then where that is being measured, whether it is being measured at the office or like the clinic measuring mainly, or whether it is being measured at home, whether it's being measured in the daytime or at night. So whether it's a 24-hour measurement or like whether it is at home or office or the clinic. So everything will have a different values that we need to look at. So that is what I would like to highlight over in this slide. And the cutoffs, wherever like depending upon where the blood pressure is being measured, will vary anywhere from 140 to 120. So we all know that the diurnal variation is also very important and the dipping is very important. So what happens at night? So that is also very important. And this is what we all need to look at to have a good proper control of the blood pressure. Now, this topic is mainly about early diagnosis or early detection and helping the CKD patients in this regard. So, what is the factors that determine or that influence that they not might not determine, but definitely they do influence the development of hypertension. And these factors are as has been listed in this slide. These are the those people who are having a family history of hypertension, those who are overweight, there is an excess consumption of sodium chloride. So how do we determine this? That's very difficult, but maybe the whole of India will come under this category. But at least those people who eat out frequently or who are mostly into pickles or any other pickled items. So those who are like into smoking, those who consume a lot of alcohol, who are inactive. So yes, that leads to overweight. And basically it's all the metabolic syndrome in one form or the other. And there are some dietary factors like potassium, calcium, magnesium intake and all that. All these things are the ones that influence the development of hypertension. So one of the most important influencing factor is the age. So that we never can let go from this list. It's not listed here, but that is something we always need to consider. Because once one of these influencing factors are present, then that is the time that we have to keep our antennas up and look for the presence of hypertension or the development of hypertension. So these are the things that we need to look out for. But once there is hypertension, so there are a lot of factors which influence the prognosis. So these are the other comorbidities that might be present in that person. So as I told you, it's all the metabolic syndrome. So metabolic syndrome definitely involves the presence of diabetes or an impaired fasting glucose in whatever form. So the presence of diabetes will have a lot of influence on the prognosis of hypertension. So ultimately, what are we looking at? We are looking at preventing the target organ damage. So if diabetes mellitus is present, or if already there is some target organ damage in any form, whether it is heart or the like brain, or whether the peripheral vascular diseases or the kidney involvement per se, or the eye involvement, which are the common organs or which we can actually look at if already any of the end organ damages are present, or if there is one more factor which can actually target these same organs, definitely the risk will be more. And yes, these are the things that determine the prognosis of hypertension. And it is in these people that we will have to be extra careful and extra vigilant in the management of hypertension. So these are pretty evident things, but if at all things are not evident, then we might have to look for asymptomatic organ damage also. So some of the things that can help us in determining this asymptomatic organ damage or a very high pulse pressure, ECG changes or echocardiographic changes. Then we can actually look at the carotid wall thickening, the difference between the carotid femoral pulse volume, ankle brachial index. These all show that there is already a vascular damage that is going on. So whether it is diabetes or hypertension, in hypertension, it is mostly the major vessels, that is the macrovascular damage that is more evident, but microvascular also is not uncommon. So both type of damages can happen. But any of the factors like these things which show us that there is already an ongoing organ damage, especially the CKD also, which will be evident in the form of microalbuminuria in the initial phases. So all these things that show us that there is an asymptomatic organ damage, and we have to be extra vigilant in this kind of patient population. So the great god of hypertension, which is Norman Kaplan. So sir already told about Brahma, Vishnu, Maheshwara, but when it comes to us mortals, so who has done a lot of work on hypertension is Norman Kaplan. So he has this famous quote: the measurement of blood pressure is the clinical procedure which is of greatest importance, but that is performed in the sloppiest manner. I am like, I think we all have to accept that none of us would be have done this BP measurement in the most ideal way that can be done. But that is something at least we should always try to achieve, and try to like do away with whatever bias that can creep up during the measurement of blood pressure. And the common sources of error in BP measurement technique are as listed below. This is important because what we are talking of is an early picking up of this hypertension, because thereby we can alter the course, whatever the target organ damage that can actually arise during the course of this hypertension. So that is why if at all we eliminate this common source of error in the blood pressure management measurement, so then we can easily tackle this. So that is always we should be looking out for these things. And if at all we have our own setup, then it is always better that we have a standard place where the person can sit and relax, and then we can go ahead and do the measurement. Then we will be able to like do away with most of the common sources of error that happens, which relates to the cuff size, how the cuff is actually applied, the position of the arm, so and the differences in the arm size, whether the patient is properly rested or not. So of course our own concentration, how good we are, and the digit bias. This is very common. This happens with most of us. Very interesting. So we always record a BP as 120 by 80 or 130 by 90 or 140 by 80, something like that. We always are very fascinated with that zero. We usually tend to do that by ourselves. So, but then definitely there is a bias there. So we can easily like either be overdoing or underdoing the measurement of hypertension in that way. And repeated measures. How many of us do repeated measures? Very unlikely that we will repeat the measurement in a single patient. And even if we repeat, are we giving the adequate time between the two measurements? So some common things which we always have to look out and try to eliminate these things from the measurement. And of course, our own devices, once we buy, like how many times have we got it calibrated? So very difficult, but something which we should watch out for. The position of the body, whether his back is resting, whether his legs are resting on the ground, whether he is keeping his legs crossed or open. So all this, the proper body position, whether he's tensed or whether he's relaxed. Our own quality of the stethoscope, of course, apart from the quality of the stethoscope, what is there in the ear and that between the ears. So everything matters, and the level of training of the measurer. So all these things are something we can take into consideration and try to eliminate the error as much as possible. Then coming to the different type of measurements. So everything will have its own advantages and disadvantages. So coming to the office blood pressure measurement, that is the clinic, then home blood pressure or ambulatory blood pressure measurement. So clinic measurement is the most common, and here in India, somehow the home blood pressure measurement, especially in the villages and like not so well-to-do people, they always feel more confident in visiting a doctor rather than measuring it by themselves. But it is disadvantages are that it is highly variable and there can be inaccurate, especially in cases of white coat and masked hypertension. And these things, this white coat hypertension and masked hypertension, it can be eliminated by the home blood pressure measurement, which is not so difficult these days. So it is very easily available. Only thing is that initially we might have to train the patient a little bit about how to properly tie, and then how to note down the readings, and then make a note of that, so that whenever they come to us, they can get all those readings and we will be able to correlate that in a better manner. And the advantages of this home blood pressure or ambulated blood pressure is that these are more in line with the target organ damage. So that is why we should always encourage people to either for home blood pressure or ambulatory. Ambulatory, we can't go in for measuring ABPM all the time because it is expensive and cumbersome, and it is limited availability. But home blood pressure is something that we should always push, and because it correlates better with the target organ damage. So rather than the clinic blood pressure measurement, give more reliance on the home blood pressure measurement. But nevertheless, whatever it is, that has to be done properly. That is what I would like to say again. So a patient of hypertension, apart from there is a list of things which we need to look at. There is a history, the physical examination, proper blood pressure measurement, and yes, there are some biochemical tests that we always need to look into, and also the imaging. These are the things that we need to look into. And accuracy and selecting a reliable disease. Apart from these things, the cuff size is very important. Most of our patient population are becoming more and more obese, and usually we try to measure everyone with the same cuff size, which is not correct. So we might be missing a lot of hypertension patients with that. So especially in obese people, we will be missing. So that is why we'll have to select the proper cuff size. And the another thing I would like to highlight again is the white coat hypertension and masked hypertension, which we should always watch out for. Whether there is a, if at all there is a like target organ damage or evidence of asymptomatic target organ damage, then it might actually be masked hypertension, which we should seek out. So, and when it comes to the screening, this is the most important. Early diagnosis is always by screening. And whom to screen? All the patients who are predisposed, as I discussed in one of the first few slides. So those are the people who need screening. But as I told, age is an important risk factor. So as of now, screening is recommended for everyone above 40. But with our present lifestyle, it doesn't hurt to start the screening even at the age of 30. So we have heard a lot of MIs and CVAs at the age of less than 40. So it definitely doesn't hurt to check the blood pressure starting from the age of 30. So if at all it is optimal, maybe as less as once in 5 years is sufficient. But if at all there is a doubt, then at least annually. And if at all they are proven, then according to whatever the proven hypertensives, so then they have to, according to the control and the target organ damage, we'll have to select like how frequently they will have to undergo the BP test. So, but screening is the important thing to get and treat hypertension at an earlier stage, which will make a difference in the outcomes. So when this is one interesting slide here. So when the blood pressure is measured both at clinic and like at home, so we can classify patients into 4 categories. So depending upon the office blood pressure, whether it is high, it's not low, it should be normal, and home, whether it is normal or high. So if at all at both places it is high, then it is like evidently it is hypertension patient. At office it is normal, but when it is measured at home, it is high. So these are like the patients which usually go unnoticed. These are the masked hypertension patients. So you'll have to take care to treat these patients without fail. And then there are another category of patients for whom the blood pressure is normal at both the places. So we need not worry much about them. They are the normal people. And there is the office blood pressure is high and the home blood pressure is normal. So these are the patients who have white coat hypertension. So I'll just go to the next slide. So the importance is that how to treat these people. So for masked hypertension, yes, the target organ damage incidence is very high and they need to be treated without fail. And for whatever the treatment be. So treatment usually starts with lifestyle changes, and soon after we might have to follow up with a pharmacological treatment if not adequately controlled. But it has to be initiated without fail for masked hypertension. And for those with white coat hypertension, it has been seen that a fair proportion of these people ultimately progress to sustained hypertension. So lifestyle changes definitely have to be instituted even for this category of patients. And the drug treatment will depend upon their cardiovascular risk. So depending upon the risk category, the treatment has to be started for the white coat hypertension people. But these people are at high risk for sustained hypertension. So definitely they require a very stringent follow-up. So these are some indications. One of the common questions, like what are the indications of ambulatory blood pressure monitoring? So these are the people in whom it is difficult to diagnose. These are the people who require ambulatory blood pressure monitoring. So I would like to tell here that hypertension patients with CKD, yes, this is one of the indications for ambulatory blood pressure monitoring. And there are some patients who are having resistant hypertension, that is blood pressure which is not controlled with three antihypertensives. So, but whenever we are dealing with such people, ruling out pseudo resistance is very important. Pseudo resistance is that there is either a problem with the drug or with the way the patient is taking the drug or with the dosage of the drug. So these things have to be eliminated before labeling them as resistant hypertension. So this is in brief about the hypertension, but hypertension cannot be completed without a mention of CKD. In 1967 itself, our favorite Gaitan, so he has described the hierarchy of the blood pressure control system. He has hypothesized, which is very much true, that the short-term control of the blood pressure is through the cardiovascular risk factors. So whether the increase in heart rate or the increased beating, so increased pressure, so all that will matter in the short-term control of blood pressure. When it comes to intermediate term, it is a fluid shift that happen between the like intravascular compartment to the extravascular compartment, the vessel tone and the hormones, these all come in the intermediate term. But when it comes to the long-term control of blood pressure, it is primarily by the kidney. So it controls most of the other systems. So that is why the long-term control of blood pressure is primarily by the kidney. And when it comes to kidney, so it is very difficult to say which comes first, whether it's a kidney problem or the hypertension. So it is always like I always give this analogy of whether what came first, whether it was a chicken or the egg. So there is no clear-cut answer for that. But with one being present, we just can't rule out the presence of the other. So there will be evident or at least an occult involvement of the other system also. And hypertensive patients most likely will develop some form of kidney damage with the time to come. And all CKD patients, even though initially they might be normotensive, by the time they reach the end stage renal disease, invariably they will have hypertension. So they are very closely associated. And this combination of hypertension and kidney disease is not going to spare any organ, whether it is the heart or the eyes or the brain. So this deadly combination has to be kept in control, which is all about controlling the hypertension in the CKD patients. And what is CKD? What is chronic kidney disease? Whether there is an anatomic or a functional damage of the kidneys which lasts for more than 3 months. So that is all CKD. That is, it is not reversible. So either there has to be anatomic damage or there has to be functional damage. Functional damage can be a decreased GFR, that is increased creatinine. There can be a protein leak in the urine. The urine sediments, there can be RBCs in urine. So these things are to be looked out for. Apart from that, these electrolyte disturbances, they are again most commonly due to the kidney disorders which needs to be looked into. And many a times, just for some other reason, an ultrasound scan is done and say they pick up some structural abnormality of the kidney. So that has to be kept in mind that these are all very high risk for development of CKD, and not just CKD, like progression of CKD and all other organ system being affected for that. So this slide I have put to highlight the fact that all these days we were always looking at only creatinine as the risk factor for the progress of the kidney disease and also the target organ damage apart from the kidneys like heart and the brain. But here in this slide, so this is not a new slide, this is like 2012. So in there itself, it has been very clearly seen that we just shouldn't stop at measurement of creatinine. And creatinine, we shouldn't stop at measurement of creatinine. We should always look at eGFR. So we have to estimate the glomerular filtration rate based upon this creatinine using the MDRD or the CKD EPA formula, which is very easily available now. All smartphones, we can just download the app and we can start calculating what is the estimated glomerular filtration rate. But it is not just the glomerular filtration rate that is important. So there is one more slide I will be showing. It is even the protein leak in the urine. So that is also has a significant effect on the target organ damage. So even though the GFR may be like somewhere around 60, there is no much difference between 59 and 60, but anyway, let's take it 59. But with the severely increased proteinuria, that is just 1 plus protein in urine, they will be at a high risk for the cardiovascular events. So this is something I wanted to highlight with this slide. And here we have the absolute numbers, like where they actually fall. So this is the slide I was referring to. So if at all we see here, so even with the eGFR of 45 to 60, the relative risk, cardiovascular risk is 1.5. But even when the eGFR is 60 to 75, with even 1 plus of protein in the urine, the risk becomes as high as 4.1. So even with the eGFR of 90, with a proteinuria, the risk factor is 3.7. So these are the two things we have to evaluate whenever we are dealing with hypertension and kidneys. That is, one is creatinine, with the creatinine to estimate the glomerular filtration rate and also look at the proteinuria. So two things. And whenever we are talking of chronic kidney disease and hypertension, so what is the pathophysiology? So there is one more slide. I will go to that directly. This one. So there are basically two important systems. That is the pressor system and the volume dependent system. Volume dependent is sodium and water. The other one is the pressor. So, but these are not alone. So there is usually a combination of all the factors. Apart from these two systems, there is a sympathetic nervous system. But these three systems in various combination will be contributing to the development of hypertension. So initially it might be anything, either volume or the pressor, that is the RAS system activation, which might be contributing to the hypertension. But with the time, as the renal problem progresses, it becomes more and more volume dependent rather than pressure dependent. But because all these things are like together, we need to target at all these systems. That is because an early treatment definitely makes a difference. This is what Dr. Arun K also was suggesting. So we have to treat them early. He was telling like how the progression has been made with good blood pressure control. The loss of GFR can be brought down to as less as 2 ml per year. So this is what this slide also highlights. So if at all we are starting the treatment at this point, maybe we can give him 2 years extra kidney life. So, but when we start it much earlier, maybe we can extend it to 11 years, give 2 more years. Maybe if at all we start much earlier, we will be able to extend it much further. So the earlier we start the treatment, so the better will be the outcomes, and definitely we can give more and more quality life to the patient. And hypertension in CKD is difficult to control because of the one of the fact is that, so as I told you, the different systems, the RAS system, the sympathetic system, and the volume dependent system, we treat one aspect, so there will be upregulation of the other system. So the counter regulatory mechanisms will come into force more. So because of this, the therapy becomes difficult to control the hypertension, and hence we have to target all the possibilities so as to achieve the good blood pressure control. So what are the key issues here? So one is the BP goal. So what is the goal? So we'll keep it as 140/90. Maybe we'll discuss about this again. And if at all there is proteinuria, maybe we have to aim for a much tighter control. And as I told earlier itself, it is not just BP control at one given point of time. It should be 24-hour control with maintenance of the nocturnal dip. And if at all there is proteinuria, AC inhibitors or ARBs are the drugs of choice. And if it is volume dependent, diuretics might be the diuretics or calcium channel blockers are the drugs of choice. So this is like the management of hypertension. So again, like everyone, all of us know this, but when it comes to the treatment, if it is not under control, so we always start with the first three drugs, A, C, or D, that is AC inhibitors or ARBs, calcium channel blockers, or diuretics. Then go on adding the other drugs when it is not under control. And if at all it is not controlled with all the three drugs put together, then we have to classify it as resistant hypertension, and maybe a specialist like nephrologist the patient should see a specialist for the control of the same, so that we rule out other problems which might be causing this resistant hypertension. So but the commonest fourth drug that is used and that is recommended these days are the aldosterone antagonist. But using AC inhibitors and ARBs plus aldosterone antagonist, something we should always watch out for is the potassium. So whenever we're using AC inhibitors or ARBs, please keep on measuring creatinine and potassium, and see that a slight increase in creatinine is very much acceptable, but it should not be beyond 30%. But then potassium control is very important, which should be looked into. So again, the similar way in a different manner. So whenever we are going on adding the secondary drugs, the comorbidities and the age and the co-prescriptions, these are the things that needs to be considered to determine which drug should come first and which drug should come second. And thereby, if at all it's a heart failure patient, definitely we can't do away with a beta blocker. So I said only ACD, but depending upon the comorbidities, we might have to go for any class of drugs that might be available. But ultimately, it is the control of hypertension which is most important. So just to summarize, we know that patients with hypertension and diabetes with CKD, they are at the very high risk of cardiovascular disease, and hence these primary factors like hypertension and diabetes has to be tackled to the maximum possible extent. And risk assessment should be performed in all patients. So don't just stop at creatinine estimation. Please go ahead and calculate the EGFR and also look at the urine protein. So this will go a long way in picking up a kidney disease at an earlier stage. And the BP goal of patients with hypertension and diabetes, these days it's been seen that the less it is kept, the better it might be. But again, there are controversies regarding that. But maybe 130/80 is a achievable goal which we should be looking into. Lifestyle modification, we should never forget this fact. Like I have not taken much time because all of us know it. Only thing is that we have to take time to inform the patient about this lifestyle modification, see that he actually practices this. And if we should not be too late in initiating the pharmacological treatment, so that we can reduce the risk at an earlier time. And white coat hypertension and masked hypertension are some things we need to look out for. If we do not look out for this, then we will be missing it. So definitely these are the two conditions we should give importance to. And most important, regular follow-up and control and discipline on the part of the patient and also on the part of the doctor also will go a long way in assuring good outcomes both for the patients and for the doctor. Thank you. Thank you all for your patient hearing. Arun sir, back to you.
Thank you, Dr. Girish, for that comprehensive overview of hypertension, and also when we have to start therapy and what we should look for when we see a patient having hypertension. Indeed, it was a depressing Saturday evening. You told us that after 150 years, we don't know how to measure hypertension. After so many years of nephrology, we don't know how to look for renal dysfunction. But the only thing you really cheered us up was by saying that hypertension is caused by lot of alcohol consumption and not by small amounts of alcohol consumption. Thank you for that. So to start our discussion today, may I request Dr. Vivekanand. I think Dr. Vivekanand is having some problems in connecting. The close relationship between the kidney and hypertension has been evident. And there is a lot of discussion about renal parenchymal disease and renal mass and hypertension. May I request Dr. Manjuna Toshiti to give his thoughts about the involvement of renal mass and hypertension, and what evidence do we have? I think there is some evidence that is available. Can you unmute yourself?
I'm audible, sir, now?
Yeah, thank you.
Yes. Okay. So coming to this renal mass and hypertension, so we all well know Brenner way back in 1988 had proposed this theory about the nephron number and hypertension and parenchymal disease. That was way back in 1988. He had proposed this hypothesis, and subsequently, few of the researchers they did a renal biopsy and compared the nephron number in patients with essential hypertension and normotension. And they found that people who have got low nephron number are predisposed to hypertension and subsequent renal damage. So what it boils down is that pathophysiology, as even Dr. Girish told, now it boils down to what is nephron heterogeneity. So each individual is of a different genetic make. So he'll have a different nephron number, and that heterogeneity will be about the post-glomerular tubular reabsorption of the sodium or related to the handling of the sodium. So the nephrons which secrete less sodium are the ones who will develop hypertension. That is what Guyton's hypothesis says, that because of nephron heterogeneity, each has a person who has got a lesser number of nephrons. Some people have more number of nephrons. Some people have adequate number of nephrons, but they do not secrete the sodium. So then there is volume retention, then increased cardiac output and increased peripheral vascular. So it is the nephron number which is related to the pathogenesis of hypertension. So this Brenner had called it as nephron dosing, nephron endowment, various terms were used. And the etiology for this nephron and low dosing is linked to maternal malnutrition, and also it is linked to maternal diabetes. They, in fact, in many of the experimental animal models, especially of many of the rats, they did a neonatal unilateral nephrectomy, and they found that they had a salt-sensitive hypertension. But this low nephron number or unilateral nephrectomy is also debated, that we have seen many of our voluntary kidney donors who donate the kidney and they don't develop hypertension, not all of them. But subsequently, off late now, there is more evidence which is emerging that even in the donors of a very, very long-term follow-up, they eventually develop quite a reasonable number of donors, they develop hypertension. So lower nephron is, the nephron number is inversely related to the development of hypertension, essential hypertension.
Thank you. Yes, again, the evidence that less kidney you have, more the chance of developing hypertension is becoming evident. And as hypertension comes in, there is a close relationship between the heart, both as well as the propagator of hypertension. May I request Dr. Vivekanand to tell us this close relationship between heart and hypertension, and how early on can we see changes in the heart, and how the heart can perpetuate hypertension in an individual.
Thank you, sir. Hypertension is associated with several target organ damage, and heart is the most important. Yes, sir. Can you hear me, sir?
Yeah, sure. Please go ahead. Yes, you're audible.
Yeah. And heart is the most important organ which is involved in hypertension. So in hypertension, heart develops left ventricular hypertrophy because it has to work against the increased peripheral vascular resistance. And this left ventricular hypertrophy leads to diastolic heart failure. And in due course of time, this LV develops a remodeling and LV gets dilated. So they may develop even systolic heart failure also. We can diagnose this left ventricular hypertrophy in early stages by echocardiography and even by ECG. In due course of time, they develop MI and stroke also because of atherosclerosis, because hypertension is an important risk factor for atherosclerosis and cardiovascular disease like MI and stroke. It is difficult to detect asymptomatic coronary artery disease in these kind of patients. So that's why in all hypertension patients after the age of 40 years, we do screen for asymptomatic coronary artery disease or carotid artery disease. But it all depends on the patient's presentation. If the patient is having a typical chest pain or other symptoms, we do treadmill test to look for any inducible ischemia. But if the patient is asymptomatic, we need to assess what is the risk of developing is the risk of stroke and MI in the next 10 years. For this, we use ASCVD risk score, which is recommended by American College of Cardiology. So it takes into account patient's age, sex, and lipid profile levels and blood pressure levels. So if the patient's ACVD risk, that is a 10-year risk of developing MI and stroke is more than 7.5%, we give statins for primary prevention. Whereas in diabetic patients, after the age of 40 years, we give blindly statins for all patients after the age of 40. But in hypertensive patients, only few patients will require statins for primary prevention. So if there is any doubt about asymptomatic coronary disease, we can take the help of CT coronary calcium scoring also. So early detection of this left ventricular hypertrophy and coronary disease is very important in hypertensive patients to prevent premature stroke or MI. And most of these hypertension patients, they also develop atrial fibrillation, which leads to congestive heart failure as well as it leads to stroke. So we need to monitor for these findings also.
Thank you, Dr. Vekanan. So it becomes evident that any component of the metabolic syndrome can be picked up. Then you think of the other components of the metabolic syndrome also. The other important thing is yes, changes start occurring early on in hypertension. So even in masked hypertension, a simple test like echocardiogram can pick up when you suspect that there is hypertension, and advances of imaging have helped us in picking up hypertension early on. But coming to the measurement of hypertension per se, why is it that we have so much of confusion? We know the fiasco that occurred with JNC8. We don't even know why, what should be the numbers for blood pressure. Why is all this confusion occurring? And of course, SPRINT study gave a totally new spin to the whole story. Dr. Girish, can you tell me why exactly this confusion occurs? Kindly unmute.
Sorry.
Sure.
The fact that there is a confusion shows that there is nothing that can be valid, and we can go ahead and say that this is the best way to do a thing. So, like it is clearly known that the cutoff, ultimately, whenever we started off with the measurement of hypertension, everybody thought that no, high blood pressure is required as your age advances to maintain your perfusion to the vital organs. But only when they started seeing that the adverse events, that is the target organ damage that happens, was more with beyond this cutoff point. So that was the time they started thinking, no, yes, this might be abnormal. That is why these things are done. And then the next further level of evidence that you treat this. So can we bring down this target organ damage? Yes, that was also proved beyond doubt that treating this thing to this level brought down the risk factor by this much percentage. But then again, there are so many studies, so many varied kinds of population. The race is different, the ethnicity is different, and the response is different. The way they are being treated is different. The drugs which are available here, which are not might not be available in US. So we all know that the Japanese and the American market doesn't agree with each other. So there are a lot of things which are not common all over the world. So definitely some discrepancies will creep in to whatever studies we are quoting at. And then one of the most important thing is like where the blood pressure is being measured. So if at all we take, you mentioned about the SPRINT. In SPRINT, the blood pressure measurement was not done by the physician. It was done when the patient was well rested with an automated blood pressure monitor, which was very accurate, and thereby they showed that it was a lower level of blood pressure which can be achieved. So, but if at all the same blood pressure were to be measured by the physician, maybe the cutoff might have been higher. This is the one thing that has been against the SPRINT, that it is not practically possible to implement. So, but ultimately, if at all we look at whatever evidence, whatever the guidelines that have evolved, so it has all varied between 120 to 140 as the systolic, and the diastolic being 80 to 90. So that is for people who are less than 60. And maybe for people who are above 60, a little relaxation by about 10 millimeters of mercury extra. So ultimately, we should individualize the treatment. So these are all guidelines. We always have to remember that whatever we are talking of are all guidelines. So, and we know that the presence of an end organ damage requires a stricter blood pressure control, but not at the sorry, but not at exposing for the all the adverse effects. So we can't go on giving diuretics to the extent of causing hyponatremia or hypokalemia, or we can't give on prescribing so that the diastolic falls to less than 60 or 50 and the patient starts having giddiness. Maybe he will get up one morning and have a fall and develops a femoral fracture, which is pretty common. So that is by individualizing the treatment and seeing that we are as close to the guideline as possible without causing any adverse events. So the guidelines are not much. Again, we shouldn't be telling that, oh, no, 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 I don't want to take risk. No, we should try to achieve what the guidelines tell us, but not at the risk of causing adverse effects to the patient. That's why individualization, and whatever guideline we take, it doesn't differ by more than 10 millimeters of mercury. So presence of end organ damage, especially for a kidney patient with proteinuria, a BP, if at all he can tolerate, it can be brought down to as less as 125/75, which is one of the suggestions by one of the societies. So that is why aim for the lowest possible BP which can be achieved. So these guidelines will help us, but definitely go on for individualization in your patients.
Thank you, Dr. Krish. So it's obvious that we need doctors, and Google cannot treat hypertension by giving numbers. So obviously safety comes first, and guidelines help us in achieving the targets we hope for, but the decision has to be made by the doctor of how to use it. So we realize that we have newer things like APPM and sorry, I think Dr. Vivekanand, we have lost him again. So the hard questions I will keep a little away, and I'll ask Dr. Manjuna Toshiti what exactly would be the thoughts that run through his mind when he starts treating a patient with newly pharmacological therapy. He starts for a newly diagnosed hypertensive. Dr. Manjunath. I think there is some problem with Dr. Manjunath.
Yes, sir.
What are the thoughts that go through your mind when you start pharmacological therapy for a newly diagnosed hypertensive?
Yes. So the moment is first newly diagnosed hypertension. Now, I assume that the question is directed at essential hypertension. So after having ruled out secondary hypertension, the first is I actually take a background of the person, the age factor and other things. So if he is a young patient, relatively somewhere in 40s, and so I would always, as we look at the pathophysiology of hypertension, is what is all revolves around salt handling. So I would always need a thiazide diuretic to be added to the regimen. And then adding what drugs as a thiazide ACE inhibitors becomes more of academic discussion. Practically, they end up requiring 2 drugs. So the first choice would be ACE inhibitor ARB with a thiazide diuretic. That would be a first choice for me. But if he's the same little elderly patient and he's having more of isolated systolic hypertension, then in that case, we would prefer a calcium channel blocker, where we need more of to overcome the systemic vascular resistance. So in that case, where they have isolated systolic hypertension, I would use a calcium channel blocker. Then it also depends upon the personality. If it's having anxiety and type A personality disorder, then you would add a beta blocker in that case. And of course, a person who is a newly diagnosed hypertension and has coexistence coronary artery disease or anything of that sort, smoker and other parameters are there, then I would add a beta blocker to that. But then for any individual, first essential hypertension, I would prefer a thiazide diuretic with a ACE inhibitor or a ARB. And for all diabetes, of course, newly diagnosed hypertension, he has got coexisting diabetes, then ACE inhibitor ARBs always come on the forefront.
Thank you. So the comorbidity profile becomes important. The things like proteinuria become important, but what is important is the number of 120 by 80 has to be reached, and achieving that is much more important. Sadly, I always compare antihypertensive therapy to our cell phones. So we started off using it as a cell phone, but how often do we use it for calling? It has now become more of a accessory for doing lots of other things, and calls become only incidental, and so it has ceased being a phone. So similarly, the pleiotropic effects became much more important later on, and so achieving the blood pressure control, which many a time may mean calcium channel blockers, may mean diuretics, become important in controlling blood pressure more than the pleiotropic effects of some new studies and some new drugs that are coming up. And I think Dr. Vivekanand has been able to join us back again. So my
Yes, sir.
question is, one part is the new, we are able to achieve better recognition of hypertension with things like ABPM. Can you just show us, throw us some light on how do you analyze a ABPM report and what does it mean to you? ABPM report?
Yes, sir. Ambulatory BP monitoring is considered to be as the gold standard for diagnosing hypertension, as well as diagnosing even masked hypertension and white coat hypertension. But it is used rarely in clinical practice. I use ambulatory BP at least once or twice in a month, especially when diagnosis of hypertension is in doubt, or when I am suspecting masked hypertension or white coat hypertension. Usually, I ask my patients to buy home BP apparatus, standard BP apparatus, and ask them to measure at home and check in the clinic also by my supervised staff. So if the blood pressure, clinic blood pressure is more than 140/90, we diagnose it as hypertension. But in home BP monitoring, it is a cutoff level is not 140/90, it is a 135/85. Similarly, in ambulatory BP also, the cutoff value of diagnosing hypertension is 135/85. But the only advantage of using ambulatory BP apparatus, it can measure even nighttime blood pressure also. So many of the normal individuals or hypertensive patients, they their blood pressure drops by 10 to 20% during night time. That is called as a nighttime dipping, which is a normal phenomenon. If the nighttime BP is not dipping, or if it is increasing, that is called a reverse dipping. It is it portends adverse prognosis. So we can detect all these changes by ambulatory BP monitoring. So nighttime cutoff level is different. It is 120/70. So if nighttime BP is more than 120/70, then also it is a hypertension. They need to be treated. So 24-hour overall average BP more than 130/80 is considered as the cutoff for ambulatory BP monitoring. So we need to know these values to correctly diagnose hypertension.
And to just continue the same question, what kind of home BP monitor would you advise, and what would be the cutoffs you would look at for patients with, say, aortic regurgitation? And how would you manage those patients? Would you label them as hypertensive?
So usually this diastolic blood pressure will be more in younger individuals, less than 50 years. So after the age of 50 years, diastolic blood pressure keeps on going, increasing. And after the age of 50 years, the systolic hypertension starts, because in elderly people, we find isolated systolic hypertension. Systolic blood pressure will be 150, 160 or 170, but diastolic blood pressure will be less than 90. So in aortic regurgitation, with this one mercury apparatus, even with the zero also, we keep on hearing the Korotkov sounds, and we don't, we take a Korotkov 4 as a cutoff. So we don't care for this diastolic blood pressure goal if the patient is having aortic regurgitation. But if the patient is not having aortic regurgitation, in elderly patients, we tend to stop at the diastolic blood pressure of 70 to 80, because below that level, if the patient is having coronary artery disease, they might develop a myocardial infarction, because most of the blood supply to the heart occurs during diastole. So for systolic cutoff, we try to target about 130 only. But in elderly patients with isolated systolic hypertension, if diastolic blood pressure is a concern, we stop at 140 or 150. We go conservatively in these kind of patients.
Thank you. So obviously the home BP monitors preferably have to be electronic because it's difficult to teach each and every person to use a sphygmomanometer. Or of course, sphygmometers are definitely out now with mercury being banned, and we are now even in the hospitals we can't use the sphygmomanometers, though they were the gold standard 2 decades back. But
Yes,
definitely
sir.
calibrated electronic machines have made life much easier, and they have also come into the clinic also, especially those machines which can will take multiple readings and relax the patient. And obviously the controversy with Sprint was put forward by Dr. Girish. And whenever we talk of hypertension, the other question that arises is that of renal artery stenosis. I just want one word from all of you, that is renal artery stenosis as prevalent as it been made out? Yeah, I think we'll start with Dr. Vivekanand.
Yes, sir. Earlier, 15 years ago, we used to do screening for renal artery stenosis in all patients undergoing coronary angiography. We used to take renal shots through femoral artery route, especially if the patient is having hypertension. So nowadays, this is totally discouraged. We should not look for renovascular hypertension aggressively if you are not planning for any revascularization. The question comes when to suspect renovascular hypertension. So renovascular hypertension is the most important cause of secondary hypertension. So out of 100 hypertension patients, 95 will be essential hypertension, and only 5% will be secondary hypertension, out of which renal artery stenosis is the most important. So normal blood pressure, essential hypertension usually develops between the ages of 35 to 55 years. So if a patient is developing hypertension below the age of 30 years and after the age of 55 years for the first time, then we should suspect secondary hypertension. And if the patient's blood pressure suddenly goes uncontrolled in a stable patient, then also we should suspect secondary hypertension. And if the patient is having asymmetrical kidneys on ultrasound abdomen, and if the patient's creatinine raises, especially if we start them on AC inhibitors or ARBs, and if the patient is coming with flash pulmonary edema, so these are all the indicators for secondary hypertension, and we should look for renal stenosis in these kind of patients.
Dr. Manjuna, your take on one sentence on renal artery stenosis.
Yes, sir. I think it's very clear that only medical management is the role. Very rarely we do a revascularization therapy. And the only indication right now for revascularization therapy is that you have found that a patient has normotensive till recently. And then you found it very short duration of hypertension, and then you find renal artery stenosis. And such are the only patients who are going to benefit from revascularization. Otherwise, for all other indications, there's no role of revascularization. And salt restriction and, of course, control of risk factors continue to be the main targets of therapy.
Dr. Girish?
As already the panelists have spoken, that's one of the important causes for secondary hypertension, and definitely a patient as has already been described. But apart from that, a well-controlled patient who suddenly becomes like a resistant kind of scenario, and those who develop electrolyte abnormalities, especially hypokalemia, maybe we need to look into renal artery stenosis as a cause. And when we are using AC inhibitors or ARBs in such a patient, if at all it is unilateral, that would be the drug of choice. But if it is bilateral, then it can actually be quite detrimental. So we have to be extra cautious and look for creatinine increase in such patients. So that is what I would like to say, sir.
I think it is quite evident that renal artery stenosis is important in the non-atherosclerotic group, which is a small percentage and obviously needs intervention. But in the atherosclerotic group, it's almost impossible to really correct it because it will come back in a few years. So only if the BP becomes very difficult to control or there are recurrent pulmonary edemas, these are the conditions probably where you will have to intervene for renal artery stenosis, though it always stays at the top of the mind of many people when we talk of hypertension. I think I have answered most of the questions that we got. As Dr. Abhijit, any more questions you have?
Yes, sir, we have some questions. I will just I posted in the chat box. And also, I would request our participants to post their questions in the chat box. So, the first question is, in aortic stenosis with high systolic blood pressure and low diastolic blood pressure, how to go ahead in such patients?
I think Dr. Vivekananda already
Yes, sir.
answered that
Yeah,
point.
most of these patients are elderly patients. In severe aortic stenosis, so there will be a systolic decapitation. So systolic blood pressure will not be high. But in our clinical practice, we have seen blood pressure up to 200 systolic, even in patients with severe hypertension. So in such patients, we need to concentrate on both systolic and diastolic blood pressure. I tend to not to decrease the diastolic blood pressure to less than 70 in such patients of aortic stenosis. So, and plan for systolic blood pressure somewhere around 140 or 150 to be on the safer side.
And sir, next question is regarding home BP measurement. What type of instrument do you advise?
In American, this International Society of Hypertension guidelines in 2020 and ESH guidelines, they have published recommendations for monitoring this home BP monitoring. They have, there is one website called as stridebp.org. There are almost 4,000 instruments are listed, which are validated by these guidelines. So anyway, we can use any one of them. Usually, I insist my patients to bring that home BP apparatus to my clinic and verify with my clinic blood pressure monitors, so that there should not be any error in measurement.
So, sir, next question is how to manage resistant hypertension in patients not responding to spironolactone?
Yeah, it's a question that I think that the question is that spironolactone is the fourth agent that you have brought in. So only even after this, if you are unable to correct the hypertension. So resistant hypertension, I think, is something which is difficult to discuss in a short time. There are so many other things we need to rule out before we call it resistant hypertension, including our recent advances in recognizing sleep hygiene and its effect on hypertension, the hidden salts that many of us take inadvertently in spite of so-called healthy eating that many people do, and the various supplements that we use, and of course the rampant use of various fizzle drinks, which all contribute a lot to the hypertension scenario. So, but to go into detail about resistant hypertension would be very difficult. And of course, the spironolactone onwards, now there are more and more drugs coming in, and even eplerenone and other drugs that are also coming in. And I think we have, our armamentarium has grown a lot, and so 4 or 5 drugs do not really stop us. But obviously, when you have such severe hypertension, there is a secondary cause only. We have failed to find that out, and recognizing it would be important.
So, one more question is there. When to refer a patient with hypertension and CKD to a nephrologist?
I think that Manjuna should answer this question.
First and foremost, any patient with presumed essential hypertension comes with having blood pressure is not controlled with 3 or more drugs, number 1. Number 2 is he's a very young hypertensive or a very elderly hypertensive. Number 3, he's got an abnormal potassium, he's got an hypokalemia, that is number 3. Number 4, of course, it's more easiest to refer when there is an abnormal creatinine. And before that, the important clues to renal hypertension would be presence of hypokalemia, uncontrolled hypertension. Then other important thing is proteinuria. So urine analysis, many a times trace or 1+ proteinuria is often overlooked upon in day-to-day practice. So that should not be included. That should be the first sign of a glomerular disease. So these are the indications where a physician should refer to a patient of hypertension to a nephrologist.
Yeah, practically, when in the clinic, yes, we now realize that we have to look at a simple thing like a urine examination, which is the poor man's kidney biopsy. Also, minor changes even in the ultrasound. Many a time would have seen mildly increased echogenicity of the kidney, which you would brush off. And sadly, we do these investigations once the patients are sick and never look back at these after the patient becomes better. And that is when you have to pick up these changes. So remember to see these reports much more carefully. Even a trace of albuminuria or a slightly increased echogenicity of the kidney can go a long way in diagnosing hypertension. And of course, when you feel that there is something wrong with the patient which you are unable to place your fingers on, always involve another brain, even if it is a nephrologist, so that you can get more clarity on the issue.
So, sir, next question is aldosteronism is underdiagnosed in our setup, as investigating renal aldosterone ratio is not easily available. So, what are your thoughts on this?
I think that Girish, you should throw us more light on hyperaldosteronism and what it means, especially in the diabetic scenario, to most of our patients.
Well, this actually has been brought out as one of the leading causes of secondary hypertension. So, and it is not easily available is one of the things we can excuse ourselves, but it is not so very difficult these days because collection centers are there everywhere. So even we can't expect all the tests to be done in all the setups, but the blood can be collected from the patient and sent to the proper lab. So which is not difficult these days. There are many courier facilities, and even the lab people themselves have the collection facilities which we can be made use of. And if at all, if it is aldosteronism, a simple aldosterone level itself is sufficient, and we might not even require a renin aldosterone ratio. So we can just stop at aldosterone level if it is evidently clear that there is hyperaldosteronism. So let us not stop at that not being available. If there is a strong suspicion because of the secondary hypertension scenario, or because of the resistant hypertension scenario, or because of the abnormal electrolytes that are suggestive of hyperaldosteronism, then we should make all the efforts to go ahead and diagnose this. And sometimes simple ultrasound also will be able to pick out some adenomas and all. So then definitely the patient himself can be referred to a higher center, because a surgical treatment will go a long way in correcting the patient himself. And but if at all there is no evident tumor or adenoma like that, then getting this test done shouldn't be very difficult all over India. That's what I feel as of now. So what do you feel, sir?
I think this is another important place where potassium comes into play. If you have a patient who has unexplained hypokalemia or even a low potassium continuously and resistant hypertension or difficult to treat hypertension, I won't call it resistant, difficult to treat hypertension, always think of hyperaldosteronism. It will be a small percentage of patients, but definitely it will be useful. And with newer drugs coming in, it is going to make a huge difference in the outcomes. And hopefully, probably that will be the sixth pillar of management of cardiac as well as cardiac events as well as hypertension, probably in the near future.
So, sir, I think due to paucity of time, we can take one more last question and then we'll close for the day, sir. So, sir, last question is role of torsemide in managing CKD, and is it superior to other diuretics?
I think Dr. Venkatesh, Dr. Vivekanand, your experience with torsemide, and because cardiologists love torsemide more than the nephrology.
I use milder diuretic thiazide like hydrochlorothiazide or chlorthalidone in early cases of hypertension. But once the patient develops CKD, these thiazide diuretics, they are of no use. So we need to use loop diuretics like torsemide if the patient's GFR is less, controlling blood pressure and to prevent other pedal edema and this one pulmonary congestion also. We need to use this loop diuretics.
I think the question
I would like to add one more point here, that torsemide, so especially in the volume overloaded status, whether it is the heart failure or the renal failure or the liver failure, the loop diuretics, as Vivekanand sir already told. So yes, once there is a abnormal kidney function, loop diuretics are definitely preferred. Then comparing between furosemide and torsemide, the absorption is what makes a difference in the treatment and the outcomes. So the furosemide absorption becomes very unreliable, especially when in the volume overload status. But whereas torsemide, the oral absorption is pretty much constant and more reliable. So the outcomes, the resolution of the CHF and the resolution of the volume overload status, the excretion of sodium, all this has seen to be better with torsemide, especially not in a normal patient, especially in a volume overloaded patient. So in such scenario, definitely torsemide scores over furosemide as the loop diuretic of choice.
I think the controversy of torsemide versus furosemide will be never ending. Basically, torsemide came to India very, very late, and I remember the 2-3 patients who came back from US almost looked at me as though I was in a primitive age because I didn't have torsemide here. But thankfully it came in. Of course, you should remember that torsemide is a prodrug and gets metabolized into 5 subunits, of which only 3 are active. So it has a prolonged action, and because of this prolonged and a plateauing action in a long-term basis, it seems to have a more stable action. And if you look at it as a drug that you are using as diuretic in hypertension, probably it scores over furosemide. And of course, in the garden variety hypertension, where the hyperkalemia is not an issue and hypokalemia becomes a worry with furosemide, torsemide scores over furosemide. Yes, Abhijit, back to you.
So, sir, since now we would be closing this session, so I would request you, sir, Dr. K. N. Arun, sir, to give your final comments on this session and your final take-home points for our participants.
Yes, it has been a good learning, and yes, we have realized that even after all these years, there is a lot to be learned about. Like the new things that are coming up is the blood pressure recording can vary even with the phase of respiration. And when I was in CMC last, there was a discussion going on about developing a monitor which will look at various phases of respiration also. And they're seeing that there is some amount of variation. So we are still a long way away from creating a proper machine to map blood pressure. And so invasive things are difficult, but they are more reliable. Very, very rarely you may have to even use that to recognize blood pressure. And various things, especially the various components of the metabolic syndrome, prevent us from getting correct readings of blood pressure in many patients. But think of a conglomerate of organ changes that can occur in metabolic syndrome. If one component is present, always look for the other component and recognize them early, correct them early. And correction doesn't mean only drugs. There is much more to recognizing organ dysfunctions, much more to recognizing secondary causes. And only if the mind is kept open can you think of this, and hope we stop becoming metering doctors, where we look at a number and try treating it and achieve better results for the patient, and keep thinking and don't become artificial intelligence, wherein we use guidelines and try to fix things into that, and keep our minds open and give the best to our patients. Thank you.
So thank you, sir. With this, we come to end of our today's session. So first of all, I would like Dr. K. N. Arun, sir, for moderating this session. That he accepted our proposal and for such an elaborative explanation of this thing. Along with him, I would also like to thank Dr. Girish, sir, for being speaker in this panel and giving an elaborative and a well-defined speech on this topic. And thanking our panelists, Dr. Manjuna sir and Dr. Vivekanand sir, to spare their time, especially on a Saturday evening, for this session. And with this, I would like to tell that this disease, CKD and hypertension, this is, as you said, sir, this is a very burning topic, or we can say very sensitive topic in management of hypertension, involvement of renal complications. So I hope today's session was useful to our participants whom I would like to especially thank to all the participants, since they are the purpose of this webinar which we have conducted. So once again, thank you everyone, and we'll just try to bring such more sessions in future. And thank you once again to Arun sir and our panelists and speakers.